Now we're going to look at a quick view of the 12-lead system. A 12-lead testing system, which generates 12 different views of the heart, provides an even more comprehensive recording. It is a lead system to use when you need to get a whole picture of the heart's electrical activity. In the 12-lead system, 6 of the leads are chest leads. The other 6 are limb leads. The A in the unipolar leads, AVR, AVL, and AVF, stands for augmented. The small waveforms that normally appear from these unipolar leads are enhanced by the ECG, and the R, L, and F stand for the positive electrode position of the lead. The R, placed on the right arm, produces a negative deflection because the heart's electrical activity moves away from the lead. The L, placed on the left arm, and the F, placed on the left leg, produce a positive deflection. The precordial lead corresponds to the modified chest lead MCL1 and shows the P wave, the QRS complex, and the ST segment particularly well. The V1 electrode is placed on the right side of the sternum at the 4th intercostal rib space. This lead helps to distinguish between right and left ventricular ectopic beats. Abnormal impulse originates from site other than the sinus node that result from myocardial irritation or other cardiac stimulation outside the normal conduction system. Lead V1 is also useful in monitoring ventricular arrhythmias, ST segment changes, and bundle branch blocks. Lead V2 is placed at the left of the sternum at the 4th intercostal rib space. Lead V3 goes between V2 and V4. Leads V1, V2, and V3 are biphasic with both positive and negative deflections. Lead V4 is placed at the 5th intercostal space at the mid-clavicular line and produces a biphasic waveform. Lead V5 is placed at the 5th intercostal space at the anterior axillary line. It produces a positive deflection on the ECG. Lead V6, the last of the precordial leads, is placed level with V4 at the mid-axillary line. Lead V6 produces a positive deflection on the ECG. A waveform, or deflection, is a movement away from the baseline in either a positive upward or a negative downward direction. An electrocardiogram, or ECG complex, represents the electrical events occurring in one cardiac cycle. A complex consists of 5 waveforms labeled with the letters P, Q, R, S, and T. The middle 3 letters, Q, R, and S, are referred to as a unit, the QRS complex. The P wave is the first component of a normal ECG waveform. P waves represent atrial depolarization, when the stimulated atria contract and push the blood through the open tricuspid and mitral valves into the relaxed ventricles. The normal P wave precedes the QRS complex and is usually rounded and upright, a positive deflection. Its height is about 2 to 3 millimeters, and its duration is 0.06 to 0.12 seconds. These characteristics indicate that the electrical impulse originated in the sinoatrial node. P waves may be hard to detect. If they are absent, it may indicate that the rhythm was generated somewhere besides the sinus node, possibly in the AV junction. P waves can also present in several ways. Some variants will depend on the ECG lead used, but some configurations indicate a problem in the atria. If the P wave configuration is pointy, notched, or double bumped, it may indicate atrial hypertrophy or enlargement associated with chronic obstructive pulmonary disease, pulmonary emboli, valvular disease, or heart failure. Ectopic P waves may be upright or inverted. They originated from somewhere other than the SA node. Intervals are comprised of a waveform and a segment. They are valuable for ECG interpretation because they represent the time between polarization cycles. The first interval on the ECG waveform is the PR interval, or PRI. It represents atrioventricular conduction time, the path of the electrical impulse through the AV node, the bundle of His, the right and left bundle branches, to the Purkinje fibers. The PRI is measured from the beginning of the P wave to the beginning of the QRS complex. The duration of the PR interval is 0.12 to 0.20 seconds. A deviation from this interval indicates abnormality. If the PR interval is prolonged, it may represent delayed conduction through the atria or AV junction. If the interval is shorter, it may indicate that the impulse originated from other than the SA node.
The QRS complex is comprised of several waveforms. The configuration of the QRS consists of the Q wave, the first negative downward deflection on the isoelectric line following the P wave, the R wave, the first positive deflection following the Q, and the S wave, a negative deflection following the R. Measure the QRS from the beginning of the Q wave to the point at which the S wave meets the ST segment, otherwise known as the J point. The duration of the normal QRS usually measures 0.04 to 0.10 seconds. The QRS complex represents ventricular depolarization when the ventricles fill with blood and contract, forcing the blood out into the arteries. Note, the QRS is larger than the P wave. As you might suspect, the reason for this is that the ventricular depolarization involves a greater muscle mass than the atrial depolarization. Evaluation of the QRS complex requires careful observation and interpretation of both duration and configuration. A QRS complex greater than 0.10 seconds may signify intraventricular conduction delay, IVCD. The QRS can also present with many faces. A deep, wide Q wave may signify myocardial infarction. A notched R wave may mean a bundle branch block. Remember, the definitions of the Q, the depolarization of the interventricular septum, R and S waves, the depolarization of the left and right ventricles. Although the QRS can come in multiple shapes and sizes, these variations do not change the definitions for each wave.
The QT interval is the part of the waveform from the beginning of the QRS complex to the end of the T wave. It represents total ventricular activity, the complete time for the ventricles to depolarize and repolarize. Thus, duration is the most critical characteristic for evaluation. Normal duration is usually 0.36 to 0.44 seconds, less than half the distance between the consecutive R waves. This duration varies with heart rate, age, and sex. Normal ranges for men are 0.39 to 0.41, and for women, 0.36 to 0.44. With a longer QT interval, the heart rate is slower, and the heart is working too hard. If the QT interval is shorter, the heart rate is faster and there is not enough time to regroup and move to the repolarization phase. To allow for this variability, a formula can be used to correct the patient's heart rate. This correction formula, the QTC, involves dividing the QT by the square root of the R to R interval. Mortality statistics support the need to be particularly alert for the duration of this interval. Basically, the desired QT interval for men should be less than 0.42, and for women it should be less than 0.44. With QT intervals that are greater than 0.44, your patient has an 8 times greater increase in mortality. If the duration increases or decreases, look at the trends to judge the importance of the variation. Also, on the unit, the QT is vital because many medications affect it. These include antiarrhythmics such as amiodarone, Ticosin, Pronestal, quinidine, and sotalol. Antibiotics such as macrolides, erythromycin and Biaxin, and fluoroquinolones. Antidepressants like tricyclics, Haldol, and HIV protease inhibitors. Many of your patients will be taking one or more of these medications, so it is important for you to be alert for the potential impact on the QT interval. Other factors that can affect the QT interval are ischemia, hyperthermia, bradycardia, any neurological imbalance, electrolyte imbalances, specifically potassium, or a recent CVA. The key message with the QT interval is look at the trends. The ST segment is between the S wave and the beginning of the T wave and represents early repolarization of the right and left ventricles. The point where the QRS complex and the ST segment meet is called the junction or J point. Although we do not measure the ST segment, any deviation in it is an abnormality that needs to be addressed. It is important to note the deflection of an ST segment. Normally, the ST segment should be flat at the isoelectric line. If the ST is elevated above the isoelectric line, repolarization is either happening abnormally or it isn't happening at all. This may indicate myocardial injury. If the ST segment is depressed below the isoelectric line, it may indicate acute ischemia. Following the ST segment is the T wave. The amplitude of the normal T wave is 0.5 millimeters in leads 1, 2, and 3, and up to 10 millimeters in the precordial lead. It may be upright, inverted, or variable depending on the lead used. The T wave represents ventricular repolarization. T waves may present differently as well. Tall, peaked T waves may indicate a potassium abnormality. Inverted T waves may indicate myocardial ischemia. The U wave is a small waveform that is not typically seen. If it is visible, it follows the T wave and is typically upright and rounded. A very prominent or unusual configuration may indicate electrolyte abnormality or medication toxicity. An inverted U wave may indicate hypertension. Normally, one complete cardiac cycle is represented by the P-QRS-T pattern. The cardiac cycle has just completed a heartbeat. First is the atrial contraction, represented by the P wave. Next comes the ventricular contraction, represented by the QRS complex. And finally, a resting state, which is represented by the T wave.